Um, this is important because I actually keep a track record so that we can share with individuals who are not able. Onye bụ ihe anọ na bed na-achị sọsọ ọchị. Afa gị bụ 676778. Ka ebe ya.
Psyche now.
John, I'm with you. I'm with you.
Okay. You know that is also all right, thank you for joining. All right, guys. So today, Dr. Nonso is gracious enough to avail his time. So Dr. Nonso, but from time to time, you know, the guy is very busy. Nonso is super busy. And so for him to avail his time like this, truly appreciate it. So I'll actually continue tuna iha today because it's eventually affecting all of us, right? I actually choose 14 also, right? And then Manoro, that time there are some of the things that you need to start doing to make sure that you are a little bit more health conscious and aware of what's going on. So I don't want to waste much time. He has 1 hour to take us through all the training. And then after the training, Dr. Nonso, you can, you have 1 hour for the training, right? You can do it for 5 minutes or what have you. But after that, we give like 30 minutes of question and answer. After that question and answer, then we do our game. The reason why we put the game at last is so we can gather everybody's attention for the time span, right? So it's going to be an engaging session. So thank you guys for joining. As of right now, we have 26 people here. That's a very, very good turnout compared to what we've had in the past. So anyone else you feel that needs to be here to learn 1 or 2 things from this session, please inform the person to join. So Dr. Nonso, if you have a PowerPoint or if you don't have, I don't know how you want to do it, but the floor is all yours now. Thank you. I'm going to mute myself.
All right. Good afternoon, everyone. It's morning for us, but it's afternoon for everyone. Everywhere in Nigeria, everywhere they do well. Some people in Nigeria, that's afternoon, and they know UK, that's afternoon. They know, Asian countries, maybe that's evening or night. But my name is Nonso. Everybody, at least most people know who I am, but today I got Bamaka, prostate. And one presentation, and I will share the presentation. Let me see. More share screen share. Perfect. And now see your screen. So opening up my screen, just raise your hand. You don't just raise your hand. Okay, perfect. Just so I know that, everybody is kind of knows and can see it. Let me see here. Minimize and project. Perfect. Okay. So, I'll generally talk about the prostate. The main concept of prostate cancer, right? And my plan is to go over understanding what the prostate is, what I go to prostate, what I mean by prostate cancer, how can you prevent here, can you treat here, what should you know, what should you not know? And I'm a bit careful to break it down in a little way for so that everybody know, you can understand what I mean. And I'm saying it because not everybody got sciences to start with. Some people got arts, so even some knowledge of biology may not be as strong. And now compared to somebody Banyezi medicine, I can easily go on and go on and miss it. What I want to say, starting is, at some point, you can raise your hand or use the Zoom, to try and raise your hand, and I'll ask and go back, because I prefer now everybody. I carry at least most people, or if possible, everybody. I want to carry everybody along from the start, so that I don't get somewhere and some people do not understand what we are saying. I'll try to break it down as much as I can so that everybody got what I hear. And as John mentioned, I'm in internal medicine, and I'll be finishing here just this is Saturday, so next week I'll be finishing next week, and then I'll be going over for fellowship, which is some higher training in medicine. For some reason, training higher at Guapo. So, so I'm on Baton Rouge. My hospital is Baton Rouge Medical Center, if you want to look at that, and I'm Louisiana. So that's a bit of introduction about. I don't need much introduction. Other introductions, everybody probably know who I am. So, by way of generally breaking it down, this is the contents. This is the high gap back today. One, can you help with the prostate? Because many people may not really know for sure what the prostate is. Because even in the biology, it's not one of those organs. The brain, the heart, the lungs, the kidney, those ones will get everybody mamakia. So some people may not really know. I'm sure most people here are not going to make a prostate, but may not really know what the prostate is and where it is, and then from there, what does the prostate do? Kihone, why did God create the prostate? What's the use? Well, one of the fascinating things about medicine, one of the things that the only organs I know that probably we don't need is the appendix. So far I've not found a very good use for it, So and sometimes it causes problems like um appendiceal cancer and things. So that's why some people, even when you are born, they try and take it out. But prostate, what use is it? And then introduction to prostate cancer, so I kind of will now go deep into the main thing, the prostate cancer, horrible. And then how can you prevent it or find it early, or the cancer deaths, why is it important? How many people now move from it? I don't know ihe ndị mmadụ ada move from why all the noise, or just ndị mmadụ eme mkpọtụ, or is it really important? And then we'll go on to treat it. If for any reason, somebody mentions that, hey, somebody has prostate cancer, okay? And what's your advice? What are the possible things in we for treatments? And then, after that, as John said, we'll go into questions. And again, I want to just carry as many people as possible along. I'll try to break it down, but if for any reason you don't understand, feel free to stop me at any point, and I'm gonna try, and break it down for body area to the level at least many people or most people got water. Okay, so prostate. Now, if we in a like na as afogi, the lower part is where the bladder is. That's where the urinary bladder. That's where the urinary bladder is, right? So that's where the bladder is. Now, under that bladder, so this first part for now, on the left-hand side, you have a level of bladder. Now, that's my left. I hope it's your left too. But if that's where the anterior part, like the person now. So if you the bladder now, just the lower part of the person's abdomen, that's basically their belly side, right? Immediately under that bladder with the prostate. Okay, and then you see the other parts of just to give you a general sense of you will see where the testicles, everybody know what we call the balls, the male balls, the testes. You see the ducts that goes up. Also, like a connection is like a thread, basically, but is a stronger thread, so to say, that has a lumen. That's basically like so things can go in and out inside the lumen, almost like pipe, just a very small, tiny pipe that is very flexible. That pipe connects the testes right up in front of the bladder and then goes into the prostate. Apart from this, and two things I about seminal vesicles. Seminal vesicles, now all these things combine to give the sperm most of the fluid you see when you have an ejaculate. Most of the things you see is the fluid. Now, most of those fluid come from the seminal vesicles, but a good part of it, a good amount of it, about 1/3, comes from the prostate. Okay. Somebody's Ikechukwu is raising his hand. Yeah. Ikechukwu, I can take your question. You can unmute.
Go on, go on, go on.
Oh, okay. So, if that seminal vesicles come down into the prostate, and then from the prostate, this part in the hair level, or yeah, but actually the urethra, that's where the urine comes out from, and that's where your ejaculate also comes out from, and that comes out to your penis, right? On the right-hand side of my screen, you see it better labeled. But what I want to focus attention there is actually that the prostate were 4 parts, right? So inside the prostate, there are distinct parts. Basically, in medicine, imago, especially with the microscope, I organs inside them with the microscope. I know he decide the parts like this part or resemble or this parts called the different. Now, in our we have 4 parts, but I want you to focus on 2: the peripheral parts, and the fibromuscular part, and the transition zone rather. Now, the peripheral parts, if you look at this on the one on the right hand side, body on the other side too, like to my right. So these two pictures, Iru the person they face it backwards, like as long as they face it together, then Iru have face the way. So on the right side of the picture, that this peripheral zone is on the back, right? So on around your back. So it's important because this is actually where the most prostate cancers come from. Now, if you look at the transitional zone, you see that the transitional zone, it's a bit of a misnomer in medicine how we name things, but the transitional zone actually wraps around the urethra. The urethra with the parts, so because it wraps around it, most of the problem from the early problems from the transition zone, the person can have problems with urination. And that is where the part where we call BPH, benign prostatic hyperplasia, which is basic. I will explain, in further slides down what exactly they mean. But just so you understand that these are the 2 parts I want you to, very keep at the back of your mind. Then as we go down, I will explain why, this is important. Now back to just what I explained to you. The peripheral zone, and they have the anterior, the central, or what I want you to remember is the peripheral zone, and that's important because that's where most cancers come from. The transitional zone is important because that's where where the BPH comes from. Now, to the things I've explained, I told you about the prostate functions, what exactly it does. The fluid you see in the ejaculates, about 30% come from the prostate. Now, it's important because that fluid from the prostate will help preserve the lifespan of the sperm, right? So sperms usually, on average, last somewhere between 24 to 48 hours. Your best shot is around 24 hours, but it can last up to 48. But that's well, some people say it lasts up to 72, but really your most best is around 48. But my point is you're able to get to that point because of the prostatic fluid. That fluid that is coming out from the prostate. Now, the prostate itself requires androgens, basically your testosterone, to grow. So testosterone is a male hormone, right? So females may have mostly estrogen from what we learned in biology, and males have mostly testosterone, right? So the testosterone that the males produce, the DNA help the prostate to grow right from development. We don't need to go into those big details. But one of the things I wanted to take away from this slide is that that fluid from the prostate contains zinc and prostatic specific antigen. you will hear us a lot, again and again, talk about PSA in prostate cancer. PSA is like, so when cells, right? So if you have a cell, inside the cell, they produce some things inside. One of the things that's this prostate gland then they produce will PSA. And this is an enzyme that helps liquefy your semen, right? So on me or they like the watery, the parts. So it's not as very thick like ammo. It just makes it a bit watery. Now, this is important because if you remember, like you're secreting that TSA to be in the semen, but a small amount of it now banana the blood, just because now I run mitochondria and blood flows everywhere. So the PSA in it produced you're going to see very high amounts in the urine, in your semen, but the most like very small amounts you will see in the blood. Now, this is important because over time, we have been able to now monitor the levels of this small enzyme to tell us how the prostate is doing. So if the prostate now normally, it should produce a very small amount, right? Less than 4 for most people. If it starts producing 10, 20, 30, 100, 200, it's a problem, right? It tells you that DNA producible 4 is now producing 100. So there's most likely a problem. It's producing more than usual. And we'll go into cancers later. Now at this point, I wanted to look at the picture on the right-hand side. All right. That is what your normal cell is like. So your normal cell, you have the nucleus, you have the cytoplasm, you have the cell membrane. I hope I'm not saying too technical things. But in cancer, there are some terms I want you to understand because, somehow you may come across something like this. The first one is what we call hypertrophy. Hypertrophy is simply a very fine word in medicine for us to say something is growing too large, no more than it's supposed to grow. Not that it is multiplying, but that it's growing too large. So, for example, if you have 4 cells, like the normal one is the one on top, that is 4. The one following it is what we call hypertrophy, right? So the hypertrophy, look at it. The cells, they are still 4, but they're now bigger, right? They've now grown like twice the size or so, but they're still 4. Now contrast that from hyperplasia. Hyperplasia, they are still the same size, but they've grown even more in number. They are no longer 4, they are now more than 4, right? So those are 2 things you keep in mind there. Metastasis, you will hear a lot in medicine and especially in cancer treatment and cancer management of what we call metastasis, means spread, right? So here possible, like everything about the prostate, God created it in such a way that everything about the prostate was then on the prostate. If at some point, if was there any was on the prostate, and if for something like the prostate somewhere in the liver, that's what we call metastasis. It should not be there, but it went there. It went there from the prostate. That's a problem. The two other terms I want you to understand is what we call cancer grade and cancer stage. Cancer grade means, look at me, you know how I look, right? Everybody knows how I look in school. If you look at me now, I might have grown more beards, but you can still, if you get my picture in DMGS, you can still say I resemble who I was then, right? That is what we call low grade, low level of differentiation. If, for example, you see somebody they call Nonso Ezeani, and you knew me in DMGS, then all of a sudden they say, "Oh, have somebody label Nonso Ezeani," but the person looks like Chinese. The person is fair. The person is short. The person has the face of Chinese, and the person speaks Mandarin. And they still say it is the same Nonso Ezeani that went to DMGS. You'll be taken aback. You just, what are mean? That is what we call high grade. It's so differentiated that it does not look like where it came from. It looks so absolutely different. It looks like a monster. That is higher grade. Stage is an encompassing term I use in medicine to say the overall classification, what is what we call your prognosis, what is your chances of survival. And we take too many things into consideration. Cancer stage is basically telling you how far spread. One of the most important things there is how far spread audit. And it makes the difference between whether you can cure cancer or whether you cannot. If you find cancer is not, cancer is not a good thing, but it may not be a terrible thing. And I say that because if you find cancer early, you have a chance of cure. And if you really cure, you don't even need further follow-ups. You don't need to continue seeing the person later. Like, you are done. Your only thing is, oh, there was one time I had cancer. I had this cancer, but I was cured. It means no follow-up, nothing. You are as good as somebody that did not have the cancer. You're fine. But if your cancer has spread and metastasized, it makes things extremely difficult. It takes away, there's no chance of cure. All you can do at that point is to reduce your risk, but to cure it, no. That's it. Okay. Now, we get into prostate cancer itself, right? Now, this is important because it's actually the most solid organ cancer in men in the US, and even more in Nigeria. Now, I'm going to talk about statistics, and I'm going to include some things in statistics. And I want everybody, to take this very seriously. One of the things I didn't understand the importance of statistics till I came to the US. I mean, we've always known that that statistics was important because we learned it in school, but I didn't see it applied to this level as it is applied in the US. It's it's crazy the amount of research that is done. And that is why you see people surviving more in the US than, say, in Nigeria. It's because people study why did people develop this condition in the first place? Who are the people that are more likely to develop this condition? And if you now look at this, then you come to the treatment and say, compare this treatment to this treatment, which one is more likely to help? And when I go down these statistics, it's the second leading cause of cancer in men, cancer deaths in men in the US after lung cancer. 1 in 9 men in the US will have lung cancer. Okay, 1 in 9. Now think about that. 1 in 9 people you meet. So if you get any 10 random, if you have 10 men in your extended family, high chance that one of them will have prostate cancer in their lifetime. We don't know who, but there's a high chance. Now, I want to mention that this is in the US. It's even higher in Nigeria, as I will show you later. And to give you a sense of, the global, just everybody, there are over 3 million diagnosed with prostate cancer in the US every year. Every year, there are over 3 million diagnosed. Now, I tried to look up the statistics in Nigeria, and it's one of the things that makes me, feel bad about our situation and where we are. Is the fact that we don't have so much research. Because I've seen what it does and the difference it can make in people's lives. Okay, research is just so important. Like, I don't know a better way to explain it, but to say it is just critically important. From the best I could see in research in Nigeria during my small search is that it's the second, in Nigeria, the most common cancer is liver cancer. After liver cancer, then you get prostate cancer in men, then breast cancer in women, then you start getting to cervical cancer in women. But this is something that you don't want to happen. Okay, the level of data we have in Nigeria, the level of research. I went to UNN. it's arguably one of the best in the East, at least, and one of the top in Nigeria. So to see that we are not doing a lot more than we should be doing is kind of heartbreaking, especially here and Imago, seeing how much you are able to do for other people. Like I treat everybody, and I love treating everybody, but if I look back and and I ask myself how many people are treating those, how many people are finding this research and doing these things in Nigeria, it just kind of breaks your heart a little bit. Now, a lot of research I will do, a lot of the things I will tell you about prostate cancer screening, you know, is from the studies that has been done in the US. And it's good that we have these studies in the US compared to somewhere maybe in East Europe or in Russia or in China. Partly because, unfortunately, because of the slave trade, you have a reasonable number of the US population as blacks. And we're hiring about NIH here, which is the National Institute of Health, which is like the government, the federal government body, just like Ministry of Health in Nigeria, that oversees research in the US. And one of the good things they've done is that they've said, nobody can do research in the US if you don't incorporate other people. When it's near other people, like every single race, you must have whites, you must have Hispanics, which is the Spanish guys, you must have blacks, you must have, so you get that representation of everybody, just so that you can, even within your studies, you can generalize it to everybody. Because if you exclude people in your research, say for example, you do only research in white people and you find something and you see a treatment is helpful there, there's no guarantee that that treatment that is helpful in white people will be helpful in black people. There's no guarantee. So that's why it's important that you include everybody. So when you are looking at it, you can look at everybody and see that that treatment works. And one of the things they have found in the US is that prostate cancer is higher in black men. Your race increases your risk for prostate cancer. I cannot say this enough. If there's one thing you're taking away, take that your risk is high as a black person, which is everybody here, right? Everybody in Nigeria is black. Now, the older you get, your higher chance of having prostate cancer, all right? It's mostly diagnosed somewhere around 66 on average. But some people can be diagnosed earlier, as we see, who the high risk, who blacks. Another risk is first degree relative with prostate cancer. And who are the first degree relatives? Your parents, your brothers, or your children. Now, your children are less likely because they are kids and they will not have grown to that point. But your parents and your siblings. Now, this is where I have to stop, to ask people. One of the things, and my mom recently just told me about it. Imagine all my years, right? I didn't know what killed my grandparents. I just know they died, and my grandmother died, and then few days later, I think it's the same week, my grandfather died, and that's all I know. My grandmother. I was talking with my mom like few weeks ago, like 2 3 weeks ago, and she said, "Oh, uh, your grandfather actually died from prostate." I said, "What?" I said, "Yes." He actually had suffered prostate, and he said then he went to normal prostate and then a general operation for the prostate. A mecha, how did she say it? A mecha the prostate went stroke from that, and then after that, make it easier. So what I know is that he had prostate problems. Is it prostate cancer? I don't know. Is it BPH? I don't know. But the point is, it helps me a whole lot to know that he had that condition, right? So then I have to keep a close eye on my dad to see, is it something that can develop in you? And then if it develops, how can we treat it early? And also for myself and for my kids. And I've loved what the Jews do. Like, in medicine, we have a lot with risk factors for Ashkenazi Jews. And you see the history, like they give you the history. Oh, this person's grandmother, this person, this person, this person. And then it drives research in medicine and it drives finding the root causes of problems. So my point here is don't blame witches, right? It's easy in Nigeria. Oh, oh, emere ọgwụ, emere ọ nwanne mami ya mere ọgwụ, nwanne mami ya mere nwanne papi ya mere ọgwụ. I'm not saying that, although, or, people had a gender dibia, but it's very important that you find out medical reasons why. Because guess what? When the grandparents, or the parents, or those people, or their children, and they go, oh, it's on the family, or in a family. It might actually be wicked in a family, but it might actually be something in the genes that predisposes you to a medical condition that people die from. And if you're able to find it early, you can actually start pursuing medical treatments and be able to escape from it. So that's my takeaway from this. And it drives me to the second point, the basics. We're getting into the meat. How do you screen and prevent prostate cancer? One of the things I want to mention is the concept of evidence-based medicine. It came about from one of the top universities in Canada, where the very first people that talks about evidence-based medicine. And what does it say? It's a way to medically prove that something is true. For example, if you say that you have this treatment for this condition, how do we know for sure? Because you get a lot of things in Nigeria where people ndị mmadụ na-ebugharị ọgwụ emixie gị ọgwụ ịṅụọ asị gị na nke a na-agwọ diabetes, ọ na-agwọ nke a, ọ na-agwọ nke a. Saying some of those things are not true, and I am aware of some herbal things that will work. But my point is, how do you prove it? Do you have proof? Now, the proof, the gold standard in medicine is what we call the randomized control trial. And what is randomized control trial? It's basically, think about it this way. And we're two people, right? And you say, for example, that drug A cures prostate cancer. How do we prove that drug A really cures prostate cancer? Or it may be concussion, it might be anything, but I acquire drug A. You know what we do? We go around and find people that have prostate cancer and find them in their thousands, so that you find a big number of them. Then you randomly means using a computer. Line is number 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, pick your number. So you randomly assign numbers to people, so that a man bias, a man say no that bisika, therefore continue heba on that the likely of continue heba. You randomly assign people into two groups, and then you expose them to the same drug. So you expose them, say for example, now the drug in a Kumakiabo drug A, you give this 500 people drug A, and give these 500 people what we call placebo. Placebo means something like chalk that absolutely has no effect. It does not harm the body, but it has no medical benefits. But you make the placebo look like drug A, such that the people taking it do not know the difference between the actual drug and the fake one, that is the placebo. And you give them those two drugs. If you give it to them, and then you monitor them over time, you monitor them equally. Most times in well-done randomized control trials, the person giving the drug does not even know. It's like it's encoded, it's like computerized. Now, the computer knows those people that actually receive drug A and those people that receive the placebo, the fake one, the chalk. And over time, at a certain time point, you now measure the two of them, right? You measure them, you now look at them. Drug A, they do better than chalk. And using computer algorithm, we now assess both of them. If those people wanted drug A did much better, like the drug, the PSA levels there were super low and everything, they lived longer than people wanted chalk, then you can authoritatively say that drug A helps, and then that chalk does not help. This is the gold standard. This is the best way to prove something. At least today, it might change in 50, 100 years' time. But today, this is the best we have. And it's important so that when when you are making decisions, you're making decisions that has been proven to work. Now, reversing back to prostate cancer screening, this is important because it helps us assess the risk and benefits. It helps us assess, for example, EJ screen people for prostate cancer. How do you prove that this energy is helpful? If you screen 100 people, for example, one of the things with prostate cancer, one of the problems we have is that the PSA is very good, but it has what we call a very high false positive rate. It basically means it detects a lot of people. So, for example, if you screen 100 people in the population, say you screen in with 100 people from DMGS, you check and had it in the right age group, it was a check for cancer. You check the levels in all of them, in all the 100. Let's say 30 of them come back positive for PSA that looks like it's prostate cancer. But in truth, only 10 of them actually have cancer, but 20 do not have cancer. Now, if you go and treat that 30 that you found, is there a chance that you will harm the 20 that did not have the disease more than you will benefit them? Because remember that it was a false positive. The PSA levels came back and got the high. Already, they did not really have the condition. But if you treat them, is there a chance you will harm them? That is the question we ask. And, I put this extra point, I've mentioned it before, how research is important. And research is expensive and takes a lot to do. It takes a lot of money. Most people now sponsor research, even here, is pharmaceutical companies, and it runs into millions of dollars. Okay, putting it in perspective, that's like billions of naira to fund one research to answer one question. And most times, again, we're like 3 different research in different areas, like MA1 Enugu, MA1 Nakanu, MA1 Lokoja. Before they decide, all 3 of them be positive. Therefore, this thing is true. Now, imagine how much it will take. Okay, you need infrastructure and you need personnel that know how to do it. So, going in to prostate cancer, we've mentioned the PSA. You know what the PSA does. You know where it comes from. Now, in the 1980s, there was this thing about almost everybody in Abia with a diagnosis with prostate cancer in the US and in several places of the world. Now, Abia, when they already have metastasis, means they have already, go spread to different organs. So you can't really cure them. So there was research into, and we find something that we can use to, find this disease early. At least if we can find it early, then we can cure it. And that's how we came about PSA. Now, just like the last slide, it came with problems. Because after they noticed the PSA, it screened where everybody, every single person was screened. And what's the problem? You have false positives. I detected my cancer for sure. But there were many people that did not really have cancer that was detected. Now, what is even more important is that this prostate cancer come in different forms. Zubi, my question.
Yes, I have it. Can you hear me?
Yeah. Go ahead.
Please, sorry for cutting you short. This PSA,
No.
what does it? Hello, this PSA,
Yeah.
what does it mean? What does it mean? This
Prostate
PSA.
specific antigen.
Prostate what?
Specific antigen. Let me
Okay,
go
no
back.
problem. All right.
Somewhere here, right? Maybe
Okay.
I didn't put it up. Sorry. It means prostate specific antigen, PSA.
Okay, prostate specific
Specific.
antigen.
Yeah,
Okay, specific.
prostate
Okay, thank you.
specific antigen, PSA.
All right.
Most
Thank
labs, even in Nigeria, just when you say PSA, they understand what you mean, but it just means prostate specific antigen.
All right, thank you.
So the point of the PSA, the research was now there was now research that and they screen so many people, and some of them are positive, some of them are negative, and they treat so many people. Remember when we get to treatment, they find some of the treatment was surgery, and therefore some of the surgery it some problems, right? Surgery comes with risk. So, and then when the person realizes that, oh, I don't really have prostate cancer, then why did you take out the person's prostate? Even more important is the fact that we now realize that there are stages, there are different kinds of prostate cancer. There are prostate cancers that are very low grade and are unlikely to metastasize. Means, when you have a prostate cancer, true. But even if Nirapoya, like Irap go to this person, maybe you need to detect the prostate cancer at 70 years. All through the person's life till 95, there was no difference. We're going to treat the prostate cancer. The person is fine. The prostate cancer won't kill you. Yes, you have prostate cancer, but it's unlikely to kill you. It will just be there, right? Then on the top is the very bad prostate cancer. If you find it early, best. If you don't find it early, give it a couple of months, it will spread. Okay, get different organs. It will kill, right? So it becomes important. How do we, and remember that there's a spectrum from this very high class to this low one that is benign and non-invincible. And that is where the US prostate, lung, colorectal, ovarian cancer trials came in, right? They started looking at everybody. If we're screening everybody for prostate cancer, is there benefits? What? The studies came back, there was no benefits. What? What have we been doing? But then a study was done in Europe. And some people argue, there's still argument between, oh, the US studies wasn't really done so well. There were contamination in the studies. It wasn't really as good as it should have been. But the European studies saw benefits, right? Now, as a result, there's this thing called the USPSTF. In this US, it means the United States Preventative Services Task Force. It's basically a task force that determines for everybody which medical condition should you be getting if you don't have disease in order to prevent it from coming. So from the name preventive, so they recommend for mammogram, they recommend for pap smear for women, they recommend for CT scan for those that are smoking to look for lung cancer, just to prevent cancer. But that's basically their task. That's all they are doing. And because of these studies, they now said, you know, there should be an informed consent between the person, between the doctor and the patient, explaining these things I've explained to you. Explain that there may be benefits, that some studies in Europe found benefits, that some studies in US did not really find benefits, and then left it to you to kind of make up your mind, or if you want to screen or if you don't want to screen. I will hammer in one important point, one important disclaimer here. All these studies were mainly in whites. There's nothing bad with them. But remember that one of the risk factors for prostate cancer is in blacks. So, and most of these studies were in, most of them, like the participants, most of those participants were whites, right? You know, just like they say, he who pays the piper dictates the tune. Right? So understand that you are already at high risk and that we don't have trials specifically looking at Black people, especially in Nigeria and other places where this risk is high. So when I come to screening itself, right? Who should be screened? When should we start? The recommended this one now is if you are going to screen, start at age 40 and screen till the person gets to 670. Because of what I've explained to you, and because some of the cancers are so strong, and some of the cancers, you know, are not like that great or that bad, the recommendation is that up to more than 70, you're likely to benefit, right? It's not likely you benefit, especially not when other medical problems. So, for example, here for some 70-year-old people, right, had a gauge, because they are so weak. The person on almost all the time. Equal and any maybe on a stroke before. Upgrading on cancer. Treatment for cancer is hectic. You know, the thing na come mad go. So only have to go weak. If in your treatment for cancer, you're likely going to kill the person, right? But therapy, maybe the person will 6 months to live, maybe 1 year, maybe 3 months. We don't know. But at least the person will live their normal life. And imago, you don't bring all these complications up to the person. Now, the disclaimer I have here is open you go 70, but you are very healthy, right? So, for example, Tinubu is how old? 70 something. I know he's kind of weak, but Atiku, for example, is 70 something, almost 80. But he's walking around. You see him looking like a very strong guy. Obviously, his money is helping him. But someone like Atiku, for example, would surely benefit because he looks healthy, right? Hopefully, he doesn't have any other medical problems that will limit him, but he's generally healthy. So those kind of people will benefit. Now, what's the benefits? I've mentioned this in brief before. It is so that you will find and treat the prostate cancer before it has spread. If you find it working on a prostate only, you will get a cure. And if you get a cure, you're done. That's it. Right? You don't need to start discussing anything again or following anything. That's it. Right? So if you find it early, treat it. That's it. You're done. And then remember that only cancer, like if you treat it and cure it, you increase the person's life expectancy. Even on person at like 65, 70, the person can potentially live to till 80. Hopefully, no more other medical problems, right? Now, I must tell you that the screening for cancer comes with its own risk, right? So, we'll talk about the biopsy, prostate biopsy. Remember, biopsy means they do something like a pin, all right? A smaller, not larger than a pin, like needle. Tinye made the prostate. Then Dokaro one small tissue from there. Dokaro is very small part. It's part I have Dokaro I not even know. Maybe my half of this my small nail. But in under the microscope, we can slice it up and then look at it and then look how bad it is. Is it? Oh my God, there's a way we know cancer on the microscope. So that way, I assume on cancer or on cancer, things like that. And then, if you do surgery.
Wait, so kawagodi health from kebe haya dunye kase adunye something in the prostate.
Okay, I think I have it. Okay, I have it here. So if you look at this, part of this is treatment. But I wanted to just show you on the right hand side. This is a CT scan. So if you're not familiar with it, I'm sorry. But like on your rectum, just like I showed in this first picture, let me go back to the first picture I showed. Yeah, here. So you see where the prostate is on the left-hand side, right? Now, imagine the person's anus on this, let me see. So the person's anus is somewhere here. So if you put your hand, one of the things we do is what we call digital rectal examination, DRE. If you put your finger here, your finger is going to go straight up to this point. So you are still in the rectum, which is part of your bowels. But you are just on a knock and mad in on the other room. America, if our auto is a use board, I don't know. So in on the other room, na board, the person on the other side can easily. I don't know, like Nigeria, cement, block, most houses. So it just not here, in or this rectum, you can feel this prostate. So sometimes they do what we call the ultrasound guided biopsy. Basically meaning I get what ultrasound probe near your rectum. And then haga straight, just like your finger, they are here. And there's just a small wall, a small thin skin separating your rectum from your prostate. And if they put a needle here, the needle is going to go straight into the prostate. And then they can take a biopsy. And that is important because, just as I explained earlier, the peripheral zone is where most cancers come from. And I explained that this is the backside. So on this left-hand picture, this peripheral zone will be somewhere here that my cursor is showing. So it's the most posterior part, is the back. So they're going to put a needle into your anus and then take a bite of this backside, meaning taking a bite of the peripheral zone. If they take a bite of that peripheral zone, then they will look at it under the microscope and see how it looks. Does this actually look like cancer or does it not? There's a newer method that they use now that I will look at that is called the transperineal method, meaning instead of going through this backside, they now go through this front side. So they put a needle directly in front of you using the ultrasound. They will go right straight in front and then go right in. But this is more complicated because just like I explained to you, the part HIA reach with this backside. So that means you have to drive all the way and cross all the way to this backside and take a biopsy.
So
that's
all prostate examination are invasive like this?
No. So I will come to the screening. Let me see here. Here. Okay, yeah, I'm here. So the screening for prostate cancer, the first thing you want to do is look at the PSA, right? So you want to look at the PSA, that's the prostate specific antigen. Once you take a look at the prostate specific antigen, normally this should be done every 2 years. For some people say 2 to 4 years. Most people will just do 2 years. Now, it has age-specific cutoffs. It has age-specific cutoffs. In general, just on average, 4 is what most people use. But it's age-specific. Like if you take for me and you now, normally our own should be less than 2. Why? Because we are young. We're in our 30s. You have no reason to have high. If you check for someone like my dad that is in his 70s, then for sure you can get up to 6. Up to 6 is normal. But most people that have prostate cancer will have higher levels, 10, 20, 30, 40. That's the first step in screening for prostate cancer, PSA, prostate specific antigen.
So these antigens are the ones that seep into the bloodstream. That's what you're testing.
Correct.
So
they're going
lower
to take
number.
your blood.
Okay, so lower number means that it's good and higher number means that it's bad.
Correct.
Okay.
Correct. Because just thinking about it, the way it seeps from, like, it's produced. Say, for example, hypothetically, inside the prostate produces 10. And out of that 10, most of it should go into your semen, right? So 8 goes into your semen. And because the prostate has blood, some of it seep into the blood. So normally you should find 1 or 2 in the blood. It makes sense, right? If the prostate is abnormal, just like we explained, hyperplasia, hypertrophy, cancer growth, they now start producing, instead of producing 10, they start producing 1,000. Most of it will still go into the semen, 800, right? But 100 may seep into the blood, and that's abnormal. That's your sign there. That's your sign that something is going wrong with the prostate, that it should not be producing these high numbers. And then you start taking a look. The word of caution here is that they may be false high numbers. And these things make sense. Why? Right? So benign prostatic hyperplasia, just like I explained in my first slide, hyperplasia, they are growing. Instead of having 4, you have 6, 8. That you can imagine that 8 will produce more than something that 4 should have normally produced. So you find higher numbers. Good thing is we can know, because the higher numbers should not be astronomically high. It should not be too high. Like there's some high numbers you start getting, you know that this is not the regular growth that is doing it. The other thing that can make the levels high is what we call the genitourinary manipulation. Somebody has had something to do in the anus, or remember the anus is very close to the prostate. So if you have something there, stimulation, you can raise the numbers. If you have a procedure done, just the cells will be agitated. It's normal that the levels can be slightly higher. So usually they try to test you when you don't have a lot of all these things going on. When you have done that, the next step in screening for prostate cancer, if your PSA is high, most times the doctor will do what we call the DRE, the digital rectal examination, which is the next one I mentioned. Now, the DRE, just like I was explaining, is going through the anus, right? So going through the anus and anus from here, riding right up. Now, if we, with just a finger, normally the normal prostate should be smooth on its surface. So if you wrap your hand on it, it should just flow smoothly. If, for example, you start feeling hard nodules, just to give you a sense, if you rub your hand on an apple, on the surface of an apple, it feels different from when you rub your hand on the front of an orange, right? So that is the difference. Then the prostate should feel like an apple. If you start feeling nodules, just like you're touching the back of an orange, it tells you that there's something here. Let me take a closer look. So that's the way we use those two things to make decisions. Now, when those two things are abnormal, this is the time for you to refer to a urologist, right? A urologist is a doctor, a surgeon that specializes in the urogenital tract. So they do things about the bladder, the prostate, the testes, all those stuff. Urologist takes care of it. And that is when you start looking at, the biopsy, as I explained, as I will talk about next. Now, if for any reason your health status it changes, you're not doing so well, then you refer, then you stop, right? Just like I explained, if you have somebody the essence of screening is so that you detect it early and treat before it becomes a problem, right? But if for some reason the person's health cannot take doing it, or for some reason, even if you detect it's not going to make any difference, then why screen for it in any way? There's no point, checking. If when you check, it's not going to make any difference. So those things are, things that you should kind of keep at the back of your mind. Now, briefly, I want to just tell you, it's not something just so that you would have an idea. But if those two things I mentioned, the PSA and the DRE, are both positive, that someone is seriously suspecting that there may be something going on here, then we do what we call the biopsy, right? As I've explained, is the transrectal, meaning they go through the rectum, and take a bite, or the transperineal, which is going through the front, go in and take a bite. This is only done when you are seriously suspecting that somebody has prostate cancer. And we take 12 cores. What does it mean? It means that, imagine that the whole gland, right? If you have, so for example, an apple, and some part of the apple are bad, and you want to detect the parts of the apple, but for some reason, this apple is hidden somewhere, right? If you want to detect it, if you take a simple bite and look under the microscope, there's a good chance that you miss it. So we take what we call a systematic biopsy cores, meaning you take 12 different areas, and those areas are distinct from each other. So it's most likely you will detect, if there's truly cancer, you will most likely detect it in at least one of them. And now the things are getting more fine-tuned. They are starting to use MRI, which is magnetic resonance imaging, to even look at where you take a biopsy, so that, if you're looking at the MRI, it can tell you if any part of the prostate looks bad. And if any part looks bad, then you go directly to that part that looks bad and take a biopsy. You're no longer just looking and taking a blind biopsy of, now let me just take everywhere. This one, you're not looking specifically at the part that you think is bad and you're taking biopsy there. It's even more fine-tuned. And I want to make the point that before we can say someone has cancer, the only definitive way to say someone has cancer is histologic, meaning we take a biopsy, we look at it under the microscope, and we see cancer in it. Then we can say that person has cancer, not through PSA, not through DRE. you must get a biopsy to say for sure someone has cancer before you even start treatment. You know, I've mentioned these parts before. Cancer grade, degree of architectural abnormality, right? Looking at me, I'm going to DMGS, you can recognize me. I've known John since, you know, secondary school. So even if John gets to 70 or 80, if I see him, I will say, this looks like John. It might not be, it might not, I might look slightly different, but I'll say, yeah, I remember him. But if he looks totally different, if he's now darker than me and much shorter than me, and he's now looking like a dwarf and he's super fat, and he totally does not look like what he was looking before. That is what we say it is so bad. So this goes from grade 1 to grade 5. 5 is very poorly differentiated. You cannot recognize that this looks like the prostate. You know, stage, degree of spread, right? And we use things here, right? We use what we call the bone scan, the CT, the PSMA, which means prostate-specific membrane antigen. Now, this is this is cool. You know, this is the PSMA scan is actually interesting. What it does is, you know, we've been able to characterize the prostate itself and the cells. So if you look at the prostate cell itself, there is something in the cell membrane. We were able to isolate this thing that is in the cell membrane of the prostate and then find something that binds to it so that when we inject it into your blood, it goes to bind the prostate gland anywhere it is in the body. When you now do a PET scan, anywhere that has the prostate, this thing we injected into you will go and bind there. And when we take the scan, it will show us everywhere that this thing was bound to. Therefore, if we take the scan and everything was bound to the prostate, then we know that most of the cancer is still in the prostate. If we take the scan and we see something binding in the brain and something binding in the lung and something binding in the liver, then we know that this thing has metastasized. It has spread to those organs for sure. So this is really cool. It helps us narrow down specifically. Unfortunately, just like Nigerian thing, you know, I think the last time we looked, there was one place in Lagos doing it. Guess how much the PET scan, this PSMA scan costs out of pocket? 1.3 million. Just for you to know if it has spread. That's not treatment yet. My time is something I'm 1 hour, and then I'll try to run down the treatments. It's not something that you absolutely need to know, but just so you have an idea. Remember that we talked about the prostate cancer, localized means it is still in the prostate, it has not spread. If you see that, then it goes down to what we talked about. You know, is it low risk? Is it poorly differentiated? If it's low risk, like it looks like the prostate, it looks like those ones that are going to be dormant and will not spread too fast, right? One of the things we do is, are you going to do active surveillance? It means defer treatment. Don't treat it. Just keep an eye on it. You know, every so often you come back and see the doctor and keep an eye. Just make sure that it's not changing. If it's changing, you treat, right? If you think that it's starting to spread more and the PSA is rising more and it's changing, treat. But if it's just there and, you know, not doing anything, just leave it alone. You don't need to worry so much about it. Or you can do watchful waiting. Watchful waiting is especially for people that have medical conditions, like someone has stroke or has other medical problems that you think, if I start treating this patient may really die, you know, because chemotherapy is tough. So you may do watchful waiting. Watchful waiting is, I don't plan to treat you. Honestly, I don't plan to treat you, except I see sign that this cancer is going to kill you. Then I step in. That's what it is. Then you get the medium to high risk ones, the ones that are more likely to spread and cause problems, right? So we see things like when you see people talking about radical prostatectomy, it means taking out everything. You take out the prostate, you take out the seminal vesicles, as I showed you, and you take out the lymph nodes. Lymph nodes are places that, so there's what we call the lymphatic drainage. So things like in your legs, fluid flow from your legs down back into your heart. One of those fluids flow in a different channel we call the lymphatic channel. So, and if cancer spreads, most likely they are spreading first to the lymph nodes. So that way, if we take away the lymph nodes, even if they spread there, you take them away and the person is unlikely to have problems. The next thing is radiotherapy. You know, sometimes we do radiotherapy before surgery, not so common anymore, or sometimes salvage after surgery. If they are still showing sign of spread after surgery, you go take it out. And the last thing they do for localized is what we call the androgen therapy. Remember, I mentioned that testosterone helps it grow, right? So what are you doing? If it's low risk and you think it's not going to be a problem, take out what helps it grow. Some people do what we call the bilateral ochiectomy, which means taking out both of the testes, or you give them a drug that chemically castrates them. You basically don't produce any testosterone. Why? Because that testosterone helps your prostate grow. So if you take away the testosterone, the prostate is not going to grow. So you just leave it there and stop its growth. I mentioned this earlier, but this is one of in the radiotherapy, there are what we call the external beam radiation, means from the outside, you just shine that radiation into that prostate and kill it, or localized, you put a seed implant, which is what we are showing here. This is the prostate, and if you see they are implanting, if you see the small parts inside the white box, there's some small parts that are trying to focus the radiation in that part. So it's very localized. That way you don't cause radiation problems to different other parts of the body. You're just very specific. Unfortunately, I think the last time I saw someone post about it, we had only one active radiation therapy in the whole of Nigeria. So it tells you how bad things are medically. Lastly, I will talk about the metastatic. Hopefully, this is not something that people that we get to experience. But just so you know, if for example, if for any reason it has metastasized, right? So you do patient-centered, focus on the patients. What are the medical problems for the patient? Remember, at this point, there's no chance of cure. You're basically trying to treat and extend the person's life as much as you can. So what does the cancer look like? How long does this person have to live? Is it someone that is already very sick and has other medical problems like heart failure that you think, I'm not sure this person is going to live for the next 2 years? Then, is it really worth it to start all the aggressive treatments that may even kill this person faster? Or should I just hands up and just kind of take things slow? So all those, it's still all the options we talked about, but you kind of at this point decide which one you want to do. Once someone has prostate cancer, you want to check their PSA for life, right? You keep monitoring, because if you have prostate cancer before, guess what? You are likely to have another one. You are more likely than other people. So you keep monitoring just so you pick it out early, cure it. And if you take away the whole prostate, it's possible that there are some that is remaining, because we are medicine, we are human. Sometimes we miss things. So we are checking every day to make sure, every year or every 2 years, to make sure that PSA is not rising. If it's rising, we want to start looking for where it's coming from early enough. Okay, that's what we mean by if they are rising PSA, you do the PSMA PET, meaning the prostate-specific membrane antigen I explained, that's trying to look at the whole body and see where the prostates are. Okay, diagnose it with a biopsy and still do treatments. I've mentioned that you screen people for life. So, in conclusion, prostate cancer is interesting. It's very important, especially in men. Early detection helps you cure it. If you don't detect it early, then there may not be chance of cure. If in the whole screening process, it's important for you to recognize the risk and benefits. And that's basically all we do in medicine, right? So we explain to you this thing can help, as things as small as paracetamol that you take. I don't know if you know that if you take too much of it, it's going to kill your liver. Yes, Christian. This will be a Christian.
So, no, so and when you want to conclude, just go ahead and finish it up, because we're about to enter question and answer.
Okay, perfect.
All right.
So, treatments, it's helpful for you to know the treatments and, know what your risks are. So that way you'll be able to make informed decisions on, should I go ahead? When should I screen? What should I be looking at? Prostate cancer treatments, okay, it helps prolong lives, but also consider the impact on the quality of life. If someone is not looking great to start with, you may not want to go ahead and start treating them. And my references is the American Urology Association and then up to date. And then I looked at the studies from Nigeria. And I'll end with my plea. It's a sincere plea. Personally, I've looked at, the more I live here, I love the things that are here, but my heart is still at home. My own perspective is that there are three things that are important, critical to change the face of Nigeria, and that's education. Okay, because education helped get me where I am, right? If you don't know, ndị Igbo si na onye njenje ka onye isi awọ. If you don't know, if you're not educated, if you don't see it and know that this can happen, then it can happen in the long run and you don't know. Health and research. You can have all the money you have in the world, and if you don't have health, that's it. Okay, I told you how much it takes to get PSMA scan just to treat prostate cancer well can bankrupt anybody. So one of the things I see at home is if people say, "Oh, I'm rich, I'm rich." You have 100 million. Really, one bad illness can knock out that 100 million in 1 month. Just one bad illness. So it's critically important that we invest in health, especially health for all. We don't have any business having malaria kill people. That it keeps me up at night all day. We absolutely have no business having malaria kill people. It should not happen in the 21st century. So we need to do that. And then governance, okay? As much as people do things, you can't really do much if you don't get your governance right. Okay, if you have rogues and criminals leading you, you don't make any difference. And I'm saying it because I know that DMGS came from missionary. We have TJ Dennis did the great work, and because of his work, that's why we are all here. So it's important that we all get involved. One of the things I don't like to hear personally is to hear people, and I heard it a lot when I was in Nigeria. Even if people are corrupt, at least is small, Ngwaru small. If we tolerate some level of corruption, I find it extremely hard to see how we will develop. I think it's critically important that we have zero tolerance. And it does not mean that we will be perfect. But when you have, just like God called us to holiness, it may not be that you have attained it. St. Paul said, not that I have attained it, but every day I walk towards it. I strive towards it. If you don't strive for something, you will not achieve it. If you say, you always be there. But if you say, I'm looking forward to, altruistic means, I'm looking forward that, like, hey, there should be zero tolerance for corruption, right? And it starts with me. I cannot be corrupt. And I will make sure I insist that there should be no corruption. It does not mean that everybody will get that correct for everybody, but we will start making progress. And give it time, you will see that difference. And then the last thing is, Dengram, I'm so proud. I cannot be prouder than I am with everything you guys are doing. I know I'm not super involved, but I've been on the sidelines, and I know something. It's been interesting text with him and me, and I know I'm not, he was asking me about the deals and everything, and I'm going to pay for sure. I mean, it's 18,000. Honestly, it's nothing to me. Like, I can pay right now, and it wouldn't flinch me, and that's something I should do. But and I just keep saying we'll keep living the light, and spread that love out loud. As much as we want everybody to pay, and I'm absolutely going to pay hopefully before today ends. But we should always maintain, you keep that love out for each other, and then build everything for each other. And with that I'll end. And I'm happy to take questions.
Thank you very much. We do appreciate your time.
Yes, that's my son. He's like 20 months, right? Yeah.
Oh wow! Congratulations.
Thank you.
Congratulations. Okay. So we're
actually expecting another baby, so he may come.
Obele, when a has me see oppress single people. It is not nice.
Oh, sorry.
So Dr. Nonso is full of surprises. But anyways, I want us to go into questions because I think there is a whole lot to unpack here, right? So forgive me, I'm going to call the names of people in the order that I see them here on my screen. So please ask your question, be very succinct, ask it directly because there were a lot of people, and then we have a game to play for the next 45 minutes. So Uzube, go ahead, unmute yourself and ask your question.
Okay. Thank you, Nonso. Can you hear me, everyone?
Yeah, I can hear you.
I can.
All right. Thank you, Nonso. Thank you for taking us through this wonderful section. It's been educative and or whatnot. I really appreciate it. Okay, my question is this. We've been hearing about this prostate every now and then, and from the little research that I did not find any cause of this prostate, like in quotes, because it's a cancer. Cancer does not have any cause. I want to know for now, is there a cause for it? And if there is a cause for it, how do someone prevent it? Because it's something that, like you said, everybody has it. It depends on when the thing started to manifest or something like that. So I want to know if there is a cause, apart from maybe is gene stuff or from hereditary or something like that. Is there a cause, particular cause, and is there something that we can do to avoid it if it is a cause? So that's my question. Thank you.
Okay, thank you. Unfortunately, we don't have a cause that we have all agreed that this is what causes it. You know, what we understand from cancer is that normally things grow, right? So just like a child grows from when you give birth to them, over time they grow. How things grow is basically that things start from um, one cell and divide into two, and then divide into four, and then divide into eight, and then divide into 12, and then divide into 16, stuff like that. For some reason, like normally when they are dividing like that, there's what we call cell regulation. Cell regulation means the ability of the body to tell itself, hey, you've grown to 8, or you wait a while. After 1 year, okay, we have room, or you grow to 16, or you wait a while, wait for 1 year. Okay, we'll grow again. That is normal. That is the normal process in the body. If for some reason that process is disrupted such that you don't have feedback mechanism, feedback means telling the body to just wait, and it starts multiplying too much. Like it doesn't tell it to stop. It just keeps growing and keeps growing and keeps growing and keeps growing and keeps growing. Over time, its characteristics change as it grows like that, and over time, it becomes cancer. There has been some reports that, oh, should you have more sex and more ejaculation? Does it help? At this time, to the best of my knowledge, I work, and to the best of the world, really, because I think it's being conservative by saying best of my knowledge. To the best of the world, there is no cure. There is no known cause. What we know about prostate cancer today is to try and know when to start looking, pick it up if it's there early enough, and then cure it. That's our best bet today. Tomorrow it could change. What we know also is as we mentioned, the risk factors, meaning things that predispose you to it. There's been some reports of smoking, because smoking has been associated with many cancers. But for so far for prostate, it's not definite. What we know for prostate cancer is only those things I've mentioned, like black race. Unfortunately, you can't change. Family history, you can't change. Age, you can't change. So far that we don't have things that I will say for sure you can change to prevent prostate cancer. I can only say if you start looking early, you can find it and treat it before it causes problems.
Quick question before we go to Austin. There was research I saw some time ago that says that men should be having more sex, that it helps to prevent all the whole prostate. So why are you laughing? It helps to prevent all the whole prostate issue. Is there like a correlation, a research on that?
Yeah, just like just like I just mentioned, there is none. At best, it's opinions. So, let me show you. Let me see. Just show you guys something here. So, a pyramid. So, there's what we call the pyramid of scientific evidence, right? So this is important, especially when people start telling you things and say, oh, this works or this does not work, or this is true or this is not true. So if you look here, right, if you look on the right hand side, what I just showed, there is one of the first things you will see is what they call let me see, accept all. You guys can still see my screen, right?
Yeah, I can see.
Yeah, so if you see the lowest level of evidence, the lowest level, like that's basically useless as in regards to people making things is expert opinion. It might be a urologist, it might be a doctor that says, oh, in my practice, I have seen that people that have more sex actually have lower risk of prostate cancer. It's your opinion. It's important in medicine, but it's your opinion. That's an expert opinion. The next is to start looking at case reports and case series, meaning looking at individual people just in small numbers and saying, oh, you've had sex all your life and then you did not have cancer. Okay, 5 people have had sex all their life, every day or every week, and they did not have cancer. Okay, that's okay. The next level of evidence is case control studies, meaning, oh, we looked back at time and found people that did not have sex and found people that have sex. And then we looked at them over time. And then, oh, the people that did not have sex had more prostate cancer. And the people that had sex have more prostate cancer. Then we get to cohort studies. And we get to the big one I mentioned to you guys, the randomized control trials. That's where you start, getting into business of making your case that this helps. And then systematic reviews. Meta-analysis is nothing but, as I mentioned to you guys, we don't just use one randomized control trial and say this is the gold standard. What we do is to compare, like if you do multiple randomized control trials, we'll now combine them and look at all of them. So that way you're looking at almost everybody that have ever done this randomized control trial. And if we still see benefits, then we say, yes, it helps. But I will tell you, in medicine, there are like 1,000 things that people say it helps. At the end of the day, only like 3 or 4 will come out through that it truly helps. So that's why I'm like, the key is doing the research. There's no randomized trial sex on sex as pertains to prostate cancer prevention. Should you have sex? If you are if you're married and you're right and your beliefs and everything, it's fine. It doesn't. What I know is sex is not going to hurt you from having prostate cancer. Is it going to help you in preventing prostate cancer? Probably not, in my opinion.
Thank you. Austin, go ahead.
Okay, so I don't know if I can be heard. I think the question is actually what he just said, because Idaho was questioning me in the news the other day that I should be having sex or I should just go and marry. But I thought that the doctor I've been seeing on Instagram also, the man has been saying that men should marry more wives, they should have more sex, it helps reduce the prostate cancer. And he has been on the internet for a while. And I've not seen like a medical doctor refute his claim. So, as you are saying in his opinion, so isn't there a way that the medical professionals, like how they can counter this kind of claims online so that people, because are people who maybe in a way to prevent the prostate cancer. Ọbụna nwunye ha they will now use it as an excuse to go out there having sex because for for anyone who teach in the church, you would have to battle with this kind of question. You know, I'm trying to prevent this illness. Now, wouldn't doing this one, having sex after of marriage or before marriage, justify the fact that I'm trying to prevent cancer? So, on a more local, the medical guys, you around account and all those things online.
Okay. My answer is two things, right? So the first thing is you raised a valid point, and just like I showed in the image, right? Like we have the hierarchy and how we make decisions and how we say for sure it helps. Not just anybody put us say this thing helps, so we'll just run and start doing it. No, it has to be tested. We have to be sure. Nobody wants to be a lab rat or an experiment, go to something that is not true. The next thing is that in the US, maybe some of those things in our phone may not happen, or it may even happen because, I mean, we've seen some news on people making things, and people have the right to make decisions, right? Especially if it doesn't hurt people directly, medically, if it doesn't hurt people. As I said, I'm not sure having sex is going to hurt you medically. You know, you're left with your conscience if you think that's right, but medically, I'm not sure it's going to help you. Whether it's going to hurt you, I don't think so, but I'm not sure it's going to help you. Whether medical professionals should counter it, the truth is, unfortunately, Nigeria does not even have enough doctors to start with. The people now does not, some of them are overworked and overwhelmed with the level of the people are caring for. It's a lot to ask them to police what people say on Facebook, or that's my opinion. I don't know how I would do it except government sets up something. And honestly, there are more than 1,000 things for government to do than going to set up who is going to police people's thoughts. I think we'll rather focus on low-hanging fruits of like, hey, this is a problem. This thing you are giving, for example, I hope we'll get to talk about kidney disease at some point. A lot of the concussions we take actually bring people to kidney cancer, or not kidney cancer, even kidney failure. And trust me, one of the most horrible things people can have that is not cancer, but it's going to drain your finances and kill you at the end is kidney disease. Okay, and that's what hurts people. And unfortunately, you see people and hawk here every time. Again, I say is even fine because it's robbing. But and I want concussion on car, I want concussion on car, I want concussion on car, on a car. Nobody has tested those things. Nobody knows what is in them. Sometimes they don't even tell you. And some of those things go on to harm your kidneys. Guess what? If you have your kidneys, you need 3 dialyses a week. One session of dialysis is over 50,000. Right? You need 3 in a week. So you need 150,000 every week. And that is 600,000 every month. Now go ahead and tell me the business you are doing in Nigeria that can easily, happily give you 600,000 every month that you can spend on dialysis. That is not when you have complications. So in my opinion, I think there are things we should focus on that is more likely to yield fruits. Some of those things that people are saying is their opinion. It's not right, but I wouldn't go policing them for now.
Thank you. Thank you. So I got Wapi also. Success, go ahead. Ask your question. Are you ready?
Hello?
Yeah, go ahead.
I'll be able to type the question.
We can't hear you.
I've dropped the question on the chat box.
Okay, you dropped the question in the chat. All right, I'm going to mute you so I can read the question. So I I was not in all the insights, and I was not in all the insight awareness. I heard you say that other health challenges can cause the increase in prostate. My dad checked himself one day and was disturbing that he had a prostate. This was after he had suffered a stroke and recovered 80%. However, after these operational procedures, I saw him change in appearance after a year and a half. He started having a constant high BP, from which he suffered dementia, and now he is no more. My question is, could it be that the procedure raised his BP? And the essence of my question sprouts when you said the fluid flows through the body stream. Does that make sense?
Yes, yes. I think I understand what he's saying. Basically, the dad had some prostate problems, had suffered a stroke, recovered, and then after the prostate surgery, he had dementia and decline, and blood pressure was difficult to control. My whole I don't know your dad, and I'm sorry with everything that happened. Success. I mean, you're very happy and easygoing guy. I know you from sex school. So my point is, he probably had the hypertension before he had the stroke, because the most common risk factor for having a stroke is hypertension. Okay, and I hope everybody here has a BP machine at home to check your blood pressure. Those are the low-hanging fruits. Okay, it's one of those things that should not happen. If you have high blood pressure, excellent. Take your medicine, check your blood pressure every day. It should be less than 130/80 every day. Now, did he have the surgery and suffered the dementia? Absolutely understandable. Remember, I said the prostate, the surgery, the radical prostatectomy is kind of a strong procedure. You know, you have the risk, and that's why I mentioned about the risk and benefits. It's some of those things that we should, and I didn't know your dad when I mentioned this. It's one of those things that you should have that discussion. Unfortunately, I'm a healthcare professional, but I think that is where we don't do well in Nigeria. Here, you don't even try it. Like, you counsel patients and tell them the risk and the benefit before any procedure. That way, they are able to look at the risk and they can weigh their chances, right? So your dad, for example, it goes back to what I'm saying. Is it possible that after he did not have even if he had the prostate cancer, that if they left him alone and left him to have the prostate cancer and then left it to grow, probably he will live longer even with the prostate cancer than going to treat it. So that's why it's important. It's not simply that, oh, I have prostate cancer, let us go and take it out immediately. What are your background risks? If you already had a stroke, you are much more likely to have dementia. So if you're going to do a very strong and very stressful procedure, it's better to make sure that your health is like almost back to normal, like you are 100%, and you know that it comes with risk. So it's possible that after the procedure he has the dementia got worse. Absolutely, because it's a lot of stress on the brain, and so someone that had a stroke, that's even more likely. But as I mentioned, it goes back to the risk and benefits. You want to have that discussion and explain what the risks are, explain what your benefits are. So when you look at them, I have a 50% chance of survival, but a 30% chance that I will die if I do this procedure. You wait. Do I really want to do this? If you don't want to do it, that's fine. But at least you understand what the risk involved. And again, I'm very sorry, what happened to your dad, and I accept my condolences.
Yeah, success. Our condolences to you. So moving on, Christian Okorie, go ahead, ask your question.
Good day. Can you...
Yeah, it's breaking.
Hello, can you hear me?
Yeah, we can hear you now.
All right. Dr. Nonso, that is so much for your time and efforts. So my question, the causes and other and whether sex not prevent here. My question, on a lifestyle or diet intervention to have strong evidence of reducing the cancer or risk of occurrence. And then the second, can you guys hear me?
Yes.
It's breaking, but go ahead.
All right, sorry. Okay. And the second question, and where you come at PSA, and where the combination in some persons that have a family history or higher risk to navigate the PSA testing and all that. Thank you.
Yeah, so that's very, very, very important question. I think I skipped that. There's been some studies that show that you cannot overemphasize the importance of diet. We found that people that eat a lot of vegetables and low-fat diets actually do have lower risk of developing prostate cancer. Okay, so the vegetables, vegetables is very important, and it goes to like many things, even colon cancer, right? Eat lots of vegetables. Don't eat a meal without a vegetable. Make fruits your friend, right? Eat lots of fruits. And I grew up in a place where my mom eats lots of fruits, so I'm kind of addicted to fruits, and that's a good thing. Get to eat many fruits. Don't eat so much buns and some of those food, especially the oils, are super saturated and they're not good for you, both with the prostate and with general life. That's with the diet. The PSA, if you have a family history, I would say, that's one step. You're already one step ahead if you know that you have a family history of prostate cancer. You're one step ahead. But what you should do is to, with everything I've explained, understand that, hey, you need screening. Okay? You need to screen. And then when are you going to start this screening? At 40. Okay, I'm about 91, so this is 2025. So I'll soon be 34. So for me, it's like in 6 years, I'm gonna start, right? And then it tells you that, oh, you start planning early. So is there something like health insurance? If you already have a family history and you are doing a regular job and you know that this may be a lot of money, you might have to invest in insurance, health insurance, and make sure it's a good insurance so that when the time comes, if you eventually are diagnosed with it, you have people that will pay for your surgery and pay for some of those tests like PSMA that is very expensive or MRI. So start by preparing yourself, like thinking about the challenges you might have in future. The Bible says, he that wants to build a house will just sit down and calculate what it costs, right? So find out what are the costs, what are the things I will need, and start building those things. So that in future, even if you have it, remember, I'm not praying anybody has it, but we are 33 people here. There is a good chance that if all of us live till 70, at least 3 of us will have it. It's not a bad thing, but it's the reality. So it's preparing yourself to know that if this thing happens, I am prepared to tackle it. That's the right step forward, I think.
Thank you. Thank you very much. Engineer Passy.
I can't hear you.
We
Or
can
can
hear
anybody
you.
hear him? Maybe he can type the question.
Okay. While you fix your audio, we'll move to Ifechukwu Winner. Winner, has your question been answered, Ifechukwu?
Froze me yourself. It's not
I think he unmuted himself. Has your question been answered? Okay, Ozioma, go ahead.
Okay. Can you hear me?
Yeah, we can hear you.
Okay. So thank you very much for the lecture. I just want to know the treatment in Kigade effective. Between prostatectomy and brachytherapy, which one the more effective and which one were more pro?
Oh, okay. That's an excellent question. An excellent question to ask. Now, in the here, let me see what is. So in localized treatments, there's actually we've looked at the treatments between radiation and radical prostatectomy, right? So the two of them in outcomes, because NMS studies, we look at the outcome in future like SABO treatments now, looking at the end, which one is better? Can they na more? Can they na add more? And when they na, so far, studies have shown that two of them have similar results. Both radical prostatectomy and radiation therapy have similar outcomes in survival. The difference is what are your comorbidities? What are the other things that you have that may that may make you more likely to suffer adverse events in one versus the other? radical prostatectomy is tough. It's taking out the whole prostate. So if you are already having medical problems, like you have just like I mentioned earlier, if you're already having like heart failure, liver disease, kidney disease, you're not already strong to start with. So probably it's better to do something that is not as stressful. That may be radiotherapy. But having said that, it is important to understand something. In Nigeria, at the time I left in 2022, we had only one functional radiation therapy in Nigeria, and I think that was in Kano. And people have people if they go to Kano today, I can get time to that you are due in 3 months. Now, in that 3 months, your cancer may have spread, or my cancer may have spread, or somebody's cancer may have spread, right? So you don't want that. So this is another point where your local resources comes to play. In Nigeria, if I am very healthy and my prostate cancer is localized and everything is in one place, for God forbid, it's better I go for prostate cancer if I am very healthy and I don't have comorbidities and I don't have all these other medical problems. Why? Because I can easily get that in Nauru to Navy. I can easily get that in UNTH. I don't have to travel. And if I go today, I can schedule the appointment and have it done next week. But if you want radiation is good, but radiation is in Kano, right? And that may be in 3 months, you're not even sure. So imagine the transport and then going, and the radiation there may not be as good. So two of them, ideally, from the US perspective, is equal. But from the Nigerian perspective, it may be different just because we don't have all the resources we need.
Okay. So in Nigeria, what you are telling me is the cons because of the distance and the timing.
Yes, the distance, the timing to do it, because you may not get that radiation. Like, to the best of my knowledge, we don't have brachytherapy in Nigeria, which is the very good therapy that is localized. If you are in somewhere like UK, brachytherapy is available, right? So if you are in the UK and other places where you have resources, the two of them are equal. Your decision will be based on, do you have other medical problems that will make you more likely to suffer the side effects from surgery? If yes, then radiation is better for you. If you are very healthy and no medical problems, just at around 50, they found it, then your best bet may be radical prostatectomy, because they take it out and you achieve a cure. Means it does not come back. You don't have it again. You don't have to ever you just go for tests to look at it. But if you go for radiation, you might do radiation now and then do radiation later. But if you do surgery, you take out all the prostates and then you've achieved the cure.
Okay. But why did you ask this question? Because based on my research here, I found out that people do more of brachytherapy compared to prostatectomy. So I was too inquisitive to know why people go for brachytherapy more. Why they always choose it.
Where are you now?
I'm San Giovanni, Rome.
So as I explained, this thing is about the same in the two of them. The outcome is the same. Surgery is, more side effects, and those people may likely have other risk factors like heart failure and other things that will make them not, be right candidates for surgery. Maybe, and then the radiation, but really the difference in them is not, there's no difference, in having the two of them. It just depends on, do you have other medical problems that it's better to do one than the other.
Okay, thank you.
Thank you. Engineer Passy, have you fixed your audio?
You're on mute, Passy. Okay.
Okay.
Yeah, we can hear you now.
Can you hear me now?
Yeah, we can hear you.
Mr. John, I want to thank you specifically for this program. And Dr. Ezeani, God bless you. I really appreciate this lesson. I've been longing for this section, prostate cancer, because of many people that I have seen that it has affected a lot. that are close to me. My question is, when you were saying something, you made mention about BPH. I really want to know the meaning of that. And the second question that I have is there anything like food that we can eat, to reduce the risk of this prostate enlargement, as they are looking for anything like food that we can eat. And, some people will say vegetarian, they will go into vegetables and all those stuff. But you can't live all your life for vegetarian. Like the things that we can eat to reduce. Thank you.
Okay. Yeah. I'll answer question one briefly. So if you go back to here, I mentioned BPH simply means benign prostatic hyperplasia. B for benign means it's not so bad. Benign in medicine means, oh, this thing is not so bad. This thing is kind of calm. And prostatic comes from the prostate. Hyperplasia is the third word on the right. That image you see there, hyperplasia. It means that if normally you have 4 prostate cells, instead of having 4, you now have more than 4. It might be 40, it might be 400, but it's way more than 4 than what it should be. It's not cancer, but it just means the prostate is big. And at this point, I would just have to add that, when people say they have prostate, ask exactly what they mean. BPH, which is benign prostatic hyperplasia, is benign. You can live all your life without surgery. You can even be on medicine that will help you urinate fine. You don't need surgery. Absolutely. I mean, will surgery help you? Yes. But you don't need surgery if you're afraid of it. You can just take medicine all your life and you will be fine. So that's what benign prostatic hyperplasia, BPH, mean. And when people say they have prostate, find out, ask Nani and I prostate. Is it BPH, which is not a big deal, or is it prostate cancer, which is a big deal? You want to find out which one is it, so that it helps you make your decisions. That's one. Then two is your second thing you asked. I answered it briefly. I don't know if you heard that, but vegetables help cut back on saturated fats. So you eat vegetable oil, eat olive oil if you can. I know it's expensive, but use olive oil to cook. Don't use groundnut oil. That's horrible. Okay. That's one. Then two, eat vegetables. And I mean, eating vegetables does not mean all your meals. I know some ladies do all vegetables because they want to lose weight. That's not what I'm saying. I'm saying if you have your meal, have a reasonable amount, have some fruits and vegetables, okay? Instead of drinking fruit juice or orange juice and doing big man, maybe you should buy 2 apples and eat 2 apples. Instead of eating orange juice, instead of drinking orange juice that is in a can, maybe buy oranges down the street and eat the orange and eat the back. That has fiber. That's what you should do. So not all your life should be only vegetables. And forget, I mean, I like soup, I like onubu, I like oha, and I'm going to eat it. If I come back to Nigeria, I'm going straight to eat all those things. So the point is, it's good to eat the regular meals, but find a way to add fruits and vegetables to your every meal. So every meal have something that is fruit and vegetable in it. That's all you need to do that will help reduce your risk. Would it prevent you from having cancer? No, but it will help reduce your risk. And that's what you should understand. And don't take it like, oh, I'm a vegetable, I'm a cancer. That's not what we're talking about. We're saying it helps you reduce the risk. So if somebody should have 10 cancers, if you eat vegetables, maybe you have 8, 7, 6, but you have less than if you don't eat it. So that's the way to look at it.
That's great. So Ugochukwu Belago is going to be our last question for the day. Victor Oji, go ahead, unmute yourself and ask your question.
Thank you, everyone. Thank you, Mr. John, for this, for organizing this. And also, thank you, Mr. Dr. Ezeani. Yes, my question is here. At what stage can somebody check this prostate cancer to know whether he has, and how can someone detect it? Can it be done probably when you want to go to hospital, can check up? You are good, okay, you want to go check up. Is he in any hospital that this is, or is it a specific hospital that comes to can do the check on these things? Thank you very much. That's my question.
Okay, thank you. I'll go down to here. So, the ages, you should start at 40. Okay, I recommend every Black person, everybody here start at 40. Why? Because the recommendation for those at higher risk, and who are higher risk? Black people. So if you are Black, you should start at 40 and screen somewhere till like 80, 69 if you don't have family history. If you're healthy after then, screen. If you, and what other thing I want to mention is you have to take your health. You know, one of the things here in the US is you have the government doing a lot for you, and it's great, but you need to be at the top of your health. You need to be the person pushing it. Here we have what we call primary care doctors, right? It means a person that you go to once in a while to say if you're having any problem, they fix it, they tell them, and those are the people that should screen you. Unfortunately, we don't have that concept ingrained in Nigeria. If I were in Nigeria and I'm like a business person and I'm a Zwafi and I'm in market, what will I do? I'll go to a government hospital. Personally, I incline towards government hospitals, especially standard government general hospitals, sometimes very good private hospitals. Like this one, anyway, this one, no, no, I mean, I don't, I hate to recommend one because I don't have any business with anybody, with any one of them. But there's this one on around Savoy or something. But the point is, find a good hospital. Don't go to one small hospital that is in a flat that is 2 bedroom or in Canada flat, like somebody's flat, not on one side, it's in one side. Because guess what? You need to trust the result in and get it from there. And you just need to only go there and say you need prostate cancer screening, PSA. Okay? Or if you want, you can even go to the people that do just labs. There is this one on a GRA. I think, who sends me that? I think it was my friend, our classmate actually, Osilo. I think it was Osilo because I was asking him because my dad needed to go for a lab. Yeah, he sent me one, non what is it called? He told me around Crescent Diagnostics, non a Niger Drive, GRA. That's what he told me because I think Osilo on Onitsha. He's practicing somewhere in Onitsha. So the point is, if you want, you can go to a good lab like this Crescent Diagnostics. I trust them because they're a very good lab. And you go there once in 2 years and say you just want to do PSA, only PSA, right? If you have other medical problems, you can test for other things, but specifically for prostate cancer, PSA, and they would do it and give you the results back. When they give you the result, you look at it. If the result is high, if you have a very high result, normally, if you look at the result, they will tell you PSA, and then they will give you your results, your level, where your PSA level is. And in brackets, they will tell you what the normal for your age is. So as I explained, like up now, it will be maybe 0 to 2. So normally, I should not see anyone in the blood, or at most, I should see 2. That's what 0 to 2 means. If they are seeing 4 or 6 or 8 or 10, beside it, they will tell you high, meaning your PSA level is high, higher than normal. If you now have that high level, then I will start looking for urologists, right? So I'm focused. I'm going to a urologist, maybe the teaching hospital in Oka, maybe the teaching hospital in Nnewi, maybe General Hospital on Onitsha. I'm not super sure, but I think they may have. And you just go, you're asking specifically, I want to see a urologist, right? Urologist. And then you give it to them. Urologists are the specialists in everything prostate. So they're going to take you down the process. And at this point, I will mention, take charge of your health. Ask questions. Okay? A lot of times in Nigeria, people don't ask questions. I mean, your doctor is assumed to have your best interest, but nothing is as good as when you have questions and you ask. And when you have health professionals, you are lucky in DOBA. We have me, you have Osilo, you have Mwedu, at least at the top of my head. And I think there's someone else that is fair that told me he did medicine. He was outside Nigeria. So those people, that at least one of them will be your friend. Make a phone call, text. Nah, I'm sorry, this prostate thing you won't mention. I checked. This is my level. What should I do? I'm going to see this doctor. He recommended this. Should I do it? Something like that. Just so it helps you make informed decisions. But that's the way I will approach it.
Thank you. Thank you very much. Obelago, go ahead. Ask your question.
All right. I want to first of all thank the executives, John, and everybody that participated in coordinating this section. I think it's really, really educative, and I didn't join earlier on, but when I was off work, I have to come in because I felt like I needed to get this information. I'm going to be practical with my questions. I've been in the healthcare sector for over 3 years now, and probably with my experience, my dad recently was diagnosed of enlarged prostate, and we have to look around what we can do, and we know his health background and all that. He's been diabetic for since, and I can't remember, maybe since in the Maria, I'm on one with diabetes, right? So definitely there are some things we should avoid. But he went to the doctor, and after the first level of examination or test and all that, this has name were a large prostate. The doctor was suggesting that we should go for another one that has to be checked to make sure not they're all cancerous, right? I didn't accept in the first place, but my God, my mom was keen on trying to be sure on the level of iodine and the rest of them. So the doctor said something about the examination or the test is going to be through the rectal area, right? I'm an onward diabetes, so definitely we're going to try as much as possible to avoid anything that is going to bring in injuries and the rest of them. So he went for that. And God being in control, he said he's not cancerous at the moment. But the doctor was also suggesting something like like kind of to take care of it to call my dad and over the 72 years as of now. Gabana to being cancerous, that he's suggesting we do operation, right? And I'm sorry to say this, but I think back in Nigeria, most of our hospitals are more financial, like hatch or ego, whatever it is that they're going to do to participate and get money, right? Instead of the individual background and their own benefit. Just like you said, any day assess the patients, what his body can be able to take, whether he's going to live more healthy and probably a settled life than going through those series of things that he can now end up declining and probably be in pain and all that. So I didn't accept the fact that he needs an operation because I'm not a diabetic. I don't know if that's going to be beneficial for him. And I think he prescribed some medications. I don't have the details of the names of the medication anyway, but like at this moment, I'm in between decisions, right? I don't know if the decisions I made is in his best interest, whether now we for the operation is going to be in his best interest. But my dad's not sure. Even after the rectal examination, he's been in pain. So you know, on accept it, right? So I'm actually backing him not to go for the operation and trying to see how long it's going to take for the rectal because I don't know if they cause an injury. So my question is, what do you think? Because at this moment, it's not cancerous. It could be, well, he's 72 years old. He's healthy apart from the diabetes and all that. But like, I don't know if the decision is in his best interest for him not to go for the operation.
No, absolutely. I mean, this is sweet. This is, this is one of the joys of having something like this, to have these candid discussions, right? And lay everything bare and say, look at this, what should we do? Now, I would say the first, just like we mentioned in this thing, he's done the first thing well, right? PSA. He has an enlarged higher PSA. They found enlarged prostate. He did a DRE. Now, what I don't know from what you mentioned is whether they did a biopsy, right? Because remember, based on the levels and based on what they see, they can know for sure, does he have prostate cancer or not? I think that will be my first step. Does he have prostate cancer or no? Now, I'm assuming that you're enlightened and everything, and I'm assuming that the person in charge is a urologist. So if the person in charge is a urologist, it begs the question that if this is purely PSA, if this is purely BPH, benign prostatic hyperplasia, without cancer, then as I said, the person can be on medicine to help them urinate, right? So it goes to, what problems does your dad have right now? My dad, I'm going to be honest with you, has prostate issues. He was vomiting at some point. At the point, I was like, I don't know what this is. Just go for a CT scan. I want the results. And they did a CT scan and they found he has prostate. But he's never told me he's really having problem urinating. But when I started teasing out, I found out, it's one of those things that as men, sometimes your parents are not so open and free to tell you that I have a problem. So, but I found that, and I'm sending him to a urologist now. Now, what you want to do is for sure prove that he does not have it, because that will make a big difference in decisions for me. My dad is 73, right? He's 73. So he makes that's how I will make the decision, or how I will advise him, because he has to make his decision. But he's like, if they look at this and absolutely he doesn't have cancer, they've looked at it with MRI, they've looked at the biopsy, he absolutely does not have cancer, then I may say, depending on how healthy he is, if he's already having health challenges and he's had, diabetes, and diabetes, is he affecting his kidneys? Does he have diabetic neuropathy, retinopathy, or nephropathy, which is fancy terms for meaning, is the diabetes affecting his eyes, his legs, his kidney? If he's affecting any of that, then it's pretty serious. I would be like, I might have to back off a little bit and just give him medicine, especially if he's not complaining too much that he's having problem urinating. I would not do a preemptive prostatectomy, meaning prostatectomy so that he does not develop cancer in future. That's nonsense. That's absolutely nonsense. Like, nobody should do it. Nobody takes away the prostate so that you don't develop cancer in future. Like, no, it's not done here. So if he has BPH, fine. If he has prostate cancer, then discussion, about the risk and benefit. And remember, I said even prostate cancer is not a reason enough for you to just go and take out the prostate. You have to see, is it that bad? Is it one of the higher grades? Is it poorly differentiated? Is it high stage that you think that this is going to cause problems? Then take it out. But if it's well differentiated and very low risk cancer, then you can as well leave it alone. He's 70. He can live up to 90 and he will be fine, even if you leave the cancer alone. So that's one. The final point I will make here is my recommendation when I'm going to do this, and I don't know the hospital he went to, but my recommendation is I try as much as possible to avoid going to private hospitals, especially if they are private hospitals that, is just one person doing one thing. Because face it, he's doing business, right? He's looking for ways to make money. If he does surgery, he will pay you for surgery. He will make his money. He's going to pay people. So he's in it for business. That's why I recommend you go to teaching hospitals. Teaching hospitals, Newi and Oka, those are the two big teaching hospitals we have in Anambra. If you go there, those doctors are paid by the government. They're not even paid by the amount of surgeries they do. So therefore, they don't have any incentive to do surgery. Whether I have one surgery or I have 10 surgery, the government will pay them the same. So they don't have an incentive to say, oh, let us go and do this surgery. They will only advise you purely based on, at least more than private hospitals, they are more likely to advise you based on what they think is best. They are unlikely to just do it for money, because the money goes to the hospital. The money doesn't go into their pockets. So they are more likely to help you. So that is the way I see it. Make that decision. If he has the prostate cancer for sure, then that's fine. But if not, then no. No, this changed all of a sudden.
Yeah, I changed it.
Oh, okay.
I changed it.
All right.
Are you done with your thoughts? So,
yes.
Iko Obela go try to connect here with Ezeani. Like, I wouldn't want this to be like, because we are kind of in a very fast-paced environment. Just last week I was on the phone with Nonso, trying to explain to him how my body is behaving. That is the benefit of being in a community. So I just came back from Europe. My body totally broke down. I was sick for 1 week, just having like different type of medical complications. And I had to reach out to somebody, none at the group, you understand, to seek for medical counsels, So please, all the marker, we need to understand the power of the community that we are building here in DOBA. Sorry, Obelago was the final question we have, but you can reach out to Nonso directly. I want us to move to this game, but before we move to the game, I just have like few things to say. I need volunteers. I need like 4 to 5 people that this thing I remember is very uplifting to me. So I would want to do more, you know. So I need them about 4 volunteers who know a lot of medical practitioners that, you know, we can fit our doctor. Nonso is very, very busy. So I know I had to, you know, pester him until he gave me a date in this June that he's free, right? And you see the presentation he did, very nice, very well prepared. It'll take you time to prepare the documentation that he presented to us. So I need to get into as many calendars of medical doctors as possible. So I need them about 4 volunteers. If you can volunteer your time in finding medical professionals that we can organize. If we can do like maybe 6 meetings like this or 7 meetings like this in a year, that would be very nice, you know. So if you know of medical professionals that you can bring to DOBA, it doesn't have to be our set. It can be somebody who is a specialist in somewhere that is willing to come. Even if they want to be paid, just let me know. We'll figure out a compensation around that. But here in Emeba is very uplifting to me. I'm learning so much. We are documenting all of these things. We're putting it on YouTube just for DOBA members. Before we go over to this game, I want to share a story. I think, Austin, I was telling you about an architect that died recently. Was my classmate and Mona Bokwa roommate in Nafuto, you know. So this guy, Baregoni Notbar, was making a lot of money and everything. And something Dr. Nonso said, he was self-medicating himself, you know. Drugs are good. I don't know if he was doing it, but what I knew that he was self-medicating himself. So only problem, maramo, typhoid, corona, or need treating malaria and all those type of things. At a point in time, kidney have failed. You know, his kidney failed because of the whole concussion in his system. So where I'm driving at with this story is that literally this guy laid on the hospital bed with a lot of wire connections on his head. I think those are EEGs, just reading like all the brain waves. But the onus of the story was that every week this guy needed 10 million to be on dialysis, to be on this, to be on this. Egoni needed this guy as an architect, right? He was designing houses. Egoni was wiped out within 2 weeks period of time. Within 2 weeks period of time, they have to be reaching out to individuals like us, and they be roommates here in the school, and they be classmates here to be doing fundraising. So when Dr. Nonso says things like health is the true wealth, I want you guys to take that very, very seriously. Because that when you have pain, you can't even concentrate. Like me last week, I was walking from my bed, from the couch, you know. That's when you understand the true value of being healthy. So if you are passionate about doing more events like this, please reach out to me. You know, I need about 4 people. That's enough. But I need people that have connections to medical doctors, you know, or even if they are not medical doctors, let them be medical practitioners, you know, people that we can bring on Zoom sessions like this and ask them questions and get some answers. So we are going to start the game real quick. I know that a lot of you have been waiting patiently for this side of things. So get your phones out. We are going to start the game now. So this is the code that you need to scan, or you just type this ahaslides.com/ this number right here. I just copied it. I'm going to put it in the chat. I'll put it in the DOBA chat, so everybody can have it there.
Sorry, John. He says scanning it. I'm doing it. I'm doing this Zoom with my system. How do I now scan?
Okay, give me a moment. It's right here. Don't worry, Zube. We'll wait for you to scan.
No, I'm done.
Uzube has been texting me since 2 days ago.
Yes, now.
Oh my goodness.
No,
We are here for you,
scanning
bro.
of it.
You
See,
must win this money.
Calm down. See, are you going to scan it with your camera? I'm having
Are you
issues.
telling me? Oh boy,
Yeah,
scan
I'm
this
asking.
thing. It's in the chat. Go to the DOBA chat. It's here.
Only they use
Okay.
iPhone. Just use your camera. Your camera will capture the QR code, and then it will show you something to click. If you just click on it, you will
I'm not
join.
using. I don't get money for iPhone.
Uzube,
I only
got to the chat. Got to DOBA chat. ATM link here, but just click here on the link. That will solve the problem.
Okay. He's not here now. He's not here in DOBA settle.
Didn't
right
you guys see
now.
the link I posted there?
No, I'm not seeing it. No link here.
I see
what's
you.
up? Go back chat. Yeah, is there?
Uzube, I just posted it again.
Okay, I'll follow me.
Is there?
I've seen it. Yeah, I've seen it. Right here, I run join.
Please make sure in that forgot because we're going to be differentiating people based on the name. So make sure that your name not put off. I don't want to have two Unzubes because I'm wearing Unzube now right now.
I ain't cause up Unzube cliff now.
Yeah, man, no Unzube cover.
That's in a cliff. Not a quarter.
Uzube, better you know, probably will go ahead.
I may win reg. I okay. My there for 2,000. I'll not give you 14,000. I'll give me own come on go and attack
All right, guys. We're gonna be starting in the next 2 minutes. Timothy, were you able to join?
Yes, I've joined.
Okay, thank God.
Okay, before we start, Nonso, is Nonso still there? I want sorry.
Yes, I'm here.
I'm not questioning. I want just to Nonso?
Huh?
Chuman address ago. Maybe reach out to him. Okay,
okay, no bother.
I'm on the John. I confirm going in at the.
All right, guys. I'm going to start the game.
Okay.
Let's go.
We don't know. Don't worry. John, question was I after.
This is my guy exam. No asking question.
No, now as I go now, submit go now.
Yeah, 20 questions. If two of 20.
Calm down. Adam
che sta questionando.
Just name that phone again. If you hear the right one.
How do I should just tap?
Yeah.
Okay. I don't think I'm getting this thing right. Yes, yes, yes.
Oh,
Doctor, no, so I would have felt this one myself. What do you think? I would have gone for all of the above.
No, but
yes,
but
now.
yeah, it's not all of the above. Like, so remember, like you're screening, right? You're screening for the cancer. What screening does is to find it early. You are checking the PSA levels. You're checking the PSA levels. Why? Because when you see high levels, you know that, oh, it might be cancer. And then you want to pick it out early.
Please,
You are not doing this so that you never develop the disease,
Okay.
right? So the essence is to find it early and treat it early when it has not spread. That way, if you treat it early, you have achieved a cure. It's definitely not to prevent cancer in your family. That's out of the question. Like, your screening doesn't affect that, whether your family members will have it or not. But it's the option B is the one that is tempting. But you have to remember that you're screening to find the cancer early. If you find it very early, you cure it. You take it out and you cure it.
Okay.
It's not so that you never have cancer.
Okay. All right.
okay.
Thank you. Good job, guys. Good job. Good job.
Hey, animal fats, herbs. Right. Animal, I Jesus. I do people herbs, animal.
Nice.